Okay, hi everyone, welcome back to my channel, and for today's video we are going to go through the most high yield stuff for endocrine. This isn't really meant for anyone who is a first time reader of first aid. Like, I recommend if you're watching these videos to have at least read first aid once, because this is mostly like just the high yield points, or maybe you're just here to watch like the stuff that you just want to memorize and kind of get over the most important details. So this is what this video series is about. The current presentation that I have for you is 85 slides. So like I said, just be aware that if this is your first time reading endocrine, this might be a little bit more difficult. This is more or less designed for people who have already read endocrine like at least once in the first aid section, or have some background in it, so you're just looking for like a refresher of like the high yield points and the things that you will likely see on questions or in a variety of question banks. So without further ado, let's just get started, and these are my high yield points for endocrine. I'm just going to read them out to you. Like I said, most of this is just going to be like buzzwords and, just like factoids, buzzwords, things that you just need to solidify in your memory. Like if you've studied endocrine before and you want to go back to refreshing yourself about it, this might be useful for you. So let's just get started. If you have a female with prolactinoma, you want to look for decreased estrogen. So remember, high levels of prolactin are going to inhibit FSH and LH, so you're going to have decreased estrogen. You're going to have increased dopamine. So how does that happen? Prolactin inhibits itself through something called a short feedback mechanism. So prolactin gets secreted, and at the same time it increases the secretion of dopamine, which is an inhibitor of prolactin secretion. That's called a short feedback mechanism. If you have a patient with hypercortisolism plus elevated urine cortisol plus elevated ACTH that is not inhibited by a large dose of DEXA, that means there's another source of the cortisol, not DEXA, that's written on here, that is not the pituitary. So when you have hypercortisolism, you want to figure out, well, is it because this patient is taking this exogenously? Is it an endogenous source, like cancer that might be secreting ACTH? Or is it coming from the pituitary? So you want to figure out what. And generally speaking, if you give a patient a large dose of DEXA, that means that the pituitary source should be suppressed, right? So if it's not inhibited by DEXA and you've done all the other tests, that means there's another source. You want to look for something outside of the pituitary, like small cell lung cancer is the most common cause. You want to look for they're called paraneoplastic syndromes, such as Lambert-Eaton. Remember that Lambert-Eaton is a presynaptic calcium channel antibodies. Keep in mind that while I'm going through these things, if I was going through like a Q bank and I found points from another topic, and then I'm going to be including it in here, and some of these things might be repeated as well because some of the questions were repeated. So you're kind of going to get like mostly yes endocrine, and you might get like a few factoids from other areas as well. So this is hopefully going to be very useful. Next point, a pituitary adenoma would be responsive, like we said, to high dose DEXA and would be suppressed. If it's not suppressed, look for something like a tumor. Next, exogenous corticosteroids should lower ACTH. Hormones produced by the supraoptic and paraventricular nucleus are two, oxytocin and ADH. So they are secreted in the hypothalamus, and then they descend down into the posterior pituitary, where they are stored and then released later. So they are formed in the supraoptic and paraventricular nucleus. Those are oxytocin, remember, that is responsible for uterine contractions and the milk letdown reflex, and you have a drug called Pitocin, which you can give to women who are in labor, which is an analog of oxytocin to induce that uterine contraction. The other hormone is ADH, or antidiuretic hormone, also called vasopressin. So it works in two ways. It works by increasing the absorption of water from the collecting tubules through upregulation of aquaporin 2, and the other way it works is directly on the blood pressure by vasoconstriction via V1 receptors. So what it does in the renal tubules, that is through aquaporin 2 via V2 receptors, and when it works on the blood vessels, it's via V1 receptors. Remember that growth hormone increases insulin-like growth factor. So this is very important. When growth hormone is being secreted, it's not very continuous and it's variable. So if you have a case of someone who has like increased growth hormone, I think they have like acromegaly or gigantism, you're not going to look directly for growth hormone because its levels fluctuate throughout the day. So you want to look for is what it increases indirectly, which is insulin like growth factor 1. And keep in mind that most of the actions of growth hormone are actually coming directly from the insulin like growth factor 1. So that's what you would look for if you have like a clinical vignette with someone who has acromegaly. The correct answer is what you would look for in the serum is insulin like growth factor 1. Next, you have a patient with a surgical neck scar from a previous thyroidectomy. The nurse tests his blood pressure and notices contraction in his arm. So what exactly is happening here? He's having hypocalcemia, very likely after the thyroidectomy. The parathyroids were removed, and now he's having symptoms of low calcium or tetany. You want to look for prolonged QT interval. Trousseau sign, perioral numbness is one of the earliest signs you would get almost immediately post-op if you've removed the parathyroids. And if you've studied surgery before, you would know that generally speaking, you would leave some of the parathyroids left. And a tidbit for you when you're studying is that a bit more advanced factoid here is that you wouldn't replace the you would take out the parathyroids, kind of like if you've seen the surgeries before, you would kind of like chop it up into like little pieces and you would stick it inside like the deltoid, for example, because if there are leftover remnants of, like, say you're removing the thyroid because the patient has thyroid cancer, you wouldn't want to go back into a surgical plane that has already healed and there's been fibrosis, and you won't be able to see where your planes are. So when you're removing a thyroid and you want to keep the parathyroid glands, you would insert them, for example, in the deltoid so that in case they have symptoms again, and then you would just remove whatever was in the arm instead of going back to a dissection plane that you can't see anything because everything is fibrosed and everything is stuck together. So that's just a little bit extra for you to know about. Hypocalcemia, look for QT prolongation. PR prolongation plus peaked T wave, hyperkalemia. So I remember hyperkalemia, like if you're looking at the Eiffel Tower, so it's like a peaked T wave. That's how I remember hyperkalemia. Torsade points is hypomagnesemia. U waves is hypokalemia. Acanthosis Necrocans, it's patches of hyperpigmentation that occur at the back of the neck and in the axilla. It's a sign of two things: insulin resistance, or a sign of malignancy like GI cancer. So if you find a patient who has, they're using the bathroom a lot, they're drinking a lot of water, and they also have these pigmentations on their axilla and the back of their neck, that is a sign of insulin insensitivity because they're headed towards progression into diabetes. Autoimmune destruction of the adrenal glands, what's that going to look like? Loss of pubic and axillary hair. So if you're going to have autoimmune destruction of the adrenal glands, you're going to have destruction of all three zones. So if you follow it through by just thinking about it, you're going to have all of the features of all of those hormones being decreased. So if you're not going to have aldosterone, you're going to have orthostatic hypotension. If you're not going to have cortisol, you're going to have decreased pubic hair and axillary hair. You're going to have increased ACTH, which is going to turn into MSH, and then you're going to have tanning of the skin and the gums. So the key thing to remember is that in the developed world, it's generally autoimmune destruction of the adrenal glands, and it could be associated with other autoimmune diseases like diabetes or Hashimoto's thyroiditis. But in the developing world, tuberculosis adrenalitis, TB adrenalitis is the more common cause. Amyloid is another cause, but it's very rare. Another thing to keep in mind is bilateral bleeding into the adrenals called Waterhouse-Friderichsen syndrome, which is caused by meningococemia. The next point is a woman delivered a baby 8 months ago, which is contraindicated for starting contraceptive. So when should she start using contraceptive, basically? OCP are contraindicated in, so I think in this clinical vignette is when should you not give it to her? If the woman is above 35 years who smokes more than 15 cigarettes per day or one pack, keep in mind that use of contraceptives within 30 days of delivery is an absolute contraindication. She would be at an increased risk of a thromboembolic event, as well as diabetes and end organ damage is another absolute contraindication to OCPs. What is a somatostatinoma? What are the buzzwords for that? You want to think of abdominal pain and weight loss and a triad of glucose. So look, the way to keep this simple, somatostatinoma, think of the word statin, is like stasis, so everything stops. So if you stop your pancreatic enzymes, you're going to have diarrhea and steatorrhea. If you stop secretion of insulin from the beta islet cells, you're going to have hyperglycemia and diabetes. If you stop the gallbladder from contracting, you're going to have gallbladder stones. So you're going to have a triad of fasting, hyperglycemia, cholelithiasis, and steatorrhea should raise concern from a tumor arising from the pancreatic delta cells, which is a somatostatinoma. So remember, somatostatin is increased. It has a primary inhibitory effect. Think of the words somatostasis. So insulin is inhibited, diabetes, diarrhea, and steatorrhea due to inhibited pancreatic enzymes, gallstones due to decreased motility of the gallbladder. Glucagonoma, the buzzword is diarrhea plus a skin rash, diabetes and a skin rash called migratory necrolytic erythema. That's keywords for glucagonoma. A VIPoma is the VIP is from vasoactive intestinal peptide. This is a classic syndrome called WDHA syndrome where they have watery diarrhea, hypokalemia, and achlorhydria. Insulinoma, the key thing, you should differentiate it from factitious disorder. So if you remember when we were studying psychiatry, some people will try to fake an illness to get attention at the hospital for a primary gain, which is they want attention and they want care and empathy from healthcare workers. How do I differentiate someone who has taken insulin on purpose so they can end up in a hospital versus an insulinoma? So insulinoma is something endogenous. So remember, when you're producing insulin, you're going to also have C-peptide levels that are elevated. So that's one way to know. Whereas on the other hand, exogenous insulin does not come with a C-peptide. So if I find the features of hypoglycemia, elevated insulin, and elevated C-peptide, okay, that's insulinoma. But if C-peptide is low, then that's looking more like factitious disorder. A gastrinoma, so gastrinoma, you're secreting lots of gastrin. So the way to think about this is you're going to have lots of ulcers. They're very resistant to treatment, and these ulcers are located in very weird areas. Usually when you think of an ulcer, you think it's in the stomach or you think it's in the duodenum, but if you did a endoscopy, you would find that you have ulcers in the jejunum or the ileum. So those are buzzwords for ulcers that are in very weird places and hinting towards a gastrinoma. Let's see. Thyroxine-binding globulin is not affected in hyperthyroid patients. Type 2 diabetes man with 3+ glucose, no ketosis, and no acidosis. So this is hyperosmolar hyperglycemic state. In this condition called HHS for short, this is very common in people who have type 2 diabetes. Their blood sugar tends to be really, really high. So it's like, think of above 800. So you're in the 800 range. This is different than DKA, which is associated with type 1 diabetes, and it's associated with levels less than 600, less than 650. HHS is 800. Because they have some insulin function, they don't have the acidosis, they don't have the ketosis that you would see with DKA. The treatment is essentially the same. Give fluids, insulin, and glucose. Pyruvate decarboxylase is the only gluconeogenic enzyme located in the mitochondria. Hyperplasia of the adrenal cortex is seen in congenital adrenal hyperplasia. A woman stops going outside. She is vegan. She gets a fracture. What is the cause? It's likely because she stopped going outside, so she's not converting vitamin D, the step that occurs in the skin with ultraviolet light UVB rays. So it's a defect in cholecalciferol vitamin D conversion from 7-dehydrocortisol, which is the first step of vitamin D synthesis that requires ultraviolet light, which occurs in the skin. So if you take a look here, if she's not going outside, right, and she's not getting that essential vitamin ultraviolet radiation, she won't be able to convert the 7-dehydrocortisol up here into cholecalciferol. So she would have this defect here, and all of the cascade down here would not be occurring as someone who's staying at home all the time. Other things to keep in mind, like all the other situations, so it's not just vegans who doesn't want to go outside. Institutionalized people don't is another example. All of the different causes of hypovitaminosis D are very important. Primary aldosteronism is going to cause hypertension and increased PCA to PAR ratio more than 10 and hypokalemia, lack of response to saline infusion tests, plus bilateral adrenal hyperplasia on CT scan. The treatment is simply a drug that blocks the aldosterone receptors called, and again, I'm not the best at pronouncing any of these, eplerenone therapy. It is preferred to surgery because if you imagine if you have primary, like bilateral situation, removing the adrenals would cause you far more issues because you would have to replace all the other hormones. So look for something that blocks the aldosterone receptors. It is referred to other aldosterone receptor blockers such as spironolactone, which causes gynecomastia. Do unilateral adrenalectomy if you find a case with only one gland, such as an adenoma. A drug that you need to be aware of is called Endocrine, which is a renin inhibitor. It would be effective in a case of hyperreninemia. I would know that there's hyperreninemia if I have a case of high blood pressure, which shows very, very high PAR, so it's not inhibiting and it's lost the whole control of blood pressure. A woman 2 weeks after delivery, she has hypotension, hypothyroidism, hypo everything. What is that? Sheehan syndrome. You want to look for a history of postpartum bleeding. What's going on here? So when a woman is pregnant, her pituitary gland, the lactotrophs, are increasing in size, and the blood supply to the pituitary is not growing in sync. So the pituitary becomes at risk of ischemia when there is a case of postpartum bleeding. So what is the treatment here? You have to replace everything. Generally, the first sign of Sheehan syndrome is failure to lactate, because you need prolactin for that. Postpartum thyroiditis, keep in mind it happens within 1 to 8 months postpartum, where she would have symptoms of hypothyroidism, but eventually it will become euthyroid. Insulin-dependent glucose transporter is GLUT4. It's found on adipocytes and striated muscles. GLUT2, you want to think two-way straight. So wherever there's GLUT2 receptors, I want that to be on organs that can sense glucose, and then at the same time deal with it. So generally that's the liver, and that's the kidney, for example. Insulin-independent GLUT1 are RBCs, astrocytes in the brain. Spermatocytes use fructose transporter GLUT5, and the placenta uses GLUT1 and GLUT3. Type 2 diabetic on metformin, it's uncontrolled. She doesn't want to gain weight, so you give her a drug called empagliflozin. The side effect is what is empagliflozin? First of all, that is an SGLT2 blocker, so it prevents the absorption of glucose from the kidney. So when that happens, all of that glucose is going to pass through into the urine, right? And the only thing you have to keep in mind is the side effect of this drug now. Candidiasis is going to love that sugar, so you're going to have an increased risk of candidiasis and urinary tract infections. In an elderly person with dementia, always look for thyroid causes. You'll hear this also when you're studying neuro, because this is a very preventable cause of dementia if you just treat the thyroid problem. So if you have an elderly person with dementia, always keep a thyroid problem as part of your differential. A patient with hypothyroidism that was treated with levothyroxine, what is the lab finding? So levothyroxine is T4. The T4 is going to be converted to T3 and RT3, or reverse T3, which is an inactive form. So keep in mind RT3 is going to be elevated. Acromegaly, what does that look like? Large face, box-like features, wide nasal bone. The patient is going to complain of hat size. This is very buzzwords. They keep changing the size of their hat, their shoes, their gloves. They have bitemporal hemianopsia due to pressure on the optic chiasm. How would you diagnose? If you remember, if I said before, you want to look for elevated serum like growth factor 1. You don't want to look for growth hormone because it's not going to be elevated all the time. What occurs in response to growth hormone is a more consistent insulin-like growth factor level elevation. And like I said before, it's this that causes the majority of the effects of growth hormone. So do not pick GH as its levels are fluctuating. They are non-specific. And they can also elevate in situations of head trauma or brain surgery. Precocious puberty. This patient is at risk of what as an adult is short stature. So if you have precocious puberty, you are secreting estrogen earlier on before your bones are able to develop, so they close the epiphyseal plates. Uncontrolled diabetes in a mother will cause insulin increase in the fetus. So this is very important. She has diabetes. The fetus is going to respond by increasing insulin. Insulin is a growth factor, so the baby's going to grow very, very large. So you're going to have macro everything. The baby's very large in weight. And then when they're born, because they have this extra insulin circulating, they're going to have features of hypoglycemia. There's other issues with untreated diabetes during pregnancy, including HOCM, which is hypertrophic cardiomyopathy, and small left colon syndrome. Fetal hyperinsulinemia will increase the metabolic demand, so that will cause hypoxia, so look for polycythemia. They will also have hypocalcemia, hypomagnesemia, and hypo-PTH, decreased PTH levels. If the diabetes was before she got pregnant, so that this is all that I've said before is regarding gestational diabetes. If it's pre-gestational diabetes, you're going to have caudal regression syndrome and restricted growth. Increased ACTH increases MSH, which is going to cause the darkening of skin and bluish gums that are seen in adrenal insufficiency. So ACTH keeps on being secreted. The adrenals can't respond by giving cortisol. You don't get that negative feedback. Some of the ACTH is going to be converted to MSH, and MSH has melanin, which is going to cause the darkening of the skin, the bluish, and the bluish gums. Insulin therapy that does not cause a peak. If you get asked what is insulin therapy that has no peak, it just keeps on, it's very leveled. That is a GLAR I'm not sure if I'm saying that correctly. It is peakless, it's basal, it's long acting, it's nearly identical to human insulin. After injection, it's going to precipitate in the subcutaneous tissue as hexamers. That hexamer is the reason why there is delayed absorption and increases the duration of action. NPH insulin is an intermediate acting and is combined with human insulin. So that's the glargine or glargine, if I'm saying it correctly. As you can see, there's no peak here. So it lasts a very, very long time. So POMC is cleaved and it forms the ACTH to MSH and beta endorphins. You might get asked what is the receptor that something along with ACTH and MSH gets secreted. What is the receptor that it works on? It's mu receptors, because beta endorphins are also cleaved from POMC. A male who has hyperthyroidism and a mass in his testicle that does not transilluminate, you want to look for a positive pregnancy test. Okay, so what is going on here? A male with a positive pregnancy test. So mass in the testicle might be a choriocarcinoma. The choriocarcinoma is secreting beta-HCG. The beta-HCG has a TSH stimulating effect, which is why he has hyperthyroidism. So if you ever get a case of a male or guys that were at a party and they started to pee on pregnancy tests just for fun, and then they realize, oh, well, it's positive. It's not a joke. This is actually a sign that they could have choriocarcinoma. Increased urine metanephrines are seen in pheochromocytoma. Non-PTH related hypercalcemia. Think of malignancies as the cause. Like we said, what are the malignancies that can cause hypercalcemia? Lymphomas, small cell lung cancer, ovarian cancer. Keep in mind multiple myeloma. The key thing that's causing all this is called PTHRP, or PTH related peptide. A patient that is on prednisone comes to the ER. Hypoglycemia, hypotension, nausea, vomiting, diarrhea. She's having adrenal crisis. How did this happen? She probably abruptly stopped her medication. So this is acute Addisonian crisis. You want to look for decreased corticotropin release hormone in response to the exogenous medication, right? So remember, if I'm taking cortisol, I don't need my brain to be signaling for my adrenals, because it's like, okay, well, I'm receiving it exogenously, so CRH is going to be decreased. A patient with previous history of prolactinoma now complains of flank pain from kidney stones and recurrent peptic ulcers. So keep in mind, prolactinoma, flank pain from kidney stones, right? So that could be due to hyperparathyroidism causing hypercalcemia, causing kidney stones. So I have the pituitary, and now have the parathyroid involved, and recurrent peptic ulcers could be due to pancreatic gastronoma, for example, like we said before. So I have 3 organs here that are involved. This could be Men1 syndrome. So Men1, you have to remember, it's from the top first. So it takes the pituitary, then the parathyroid, then the pancreas. I believe Men2 is pheochromocytoma, then the pancreas, then the parathyroids, and then the I may be making a mistake here. Let's just keep going before I make another mistake. Anyway, so Men1 syndrome is due to altered menin protein. If you get mutation of VHL, what is VHL? Von Hippel-Lindau disease. You want to look for renal cell. A whole bunch of carcinomas are involved with VHL. Renal cell carcinoma, pheochromocytoma, hemangioblastoma. If you get a buzzword like mutation in c-KIT, what is c-KIT? That is found in GIST, or gastrointestinal stromal tumors. Altered Merlin gene expression, so don't confuse Merlin with menin. So if you're getting a case of Men syndrome and you get confused, oh wait, it was Merlin, it was menin. Menin for Men syndrome, Merlin for neurofibromatosis 2, which is on chromosome 22. Inactivation of RET is proto-oncogene is Men2. A male with headache and loss of his peripheral vision, CT scan reveals a large cellular mass. It's likely a prolactinoma. You want to look for impotence. So increased prolactin is going to cause hypogonadism. The low LH is going to cause low testosterone. The low testosterone is going to cause erectile dysfunction. The erectile dysfunction is going to cause decreased libido, decreased testicular volume. Galactorrhea is not as likely. Don't pick galactorrhea if you find this question. Signs of hyperthyroidism plus a cellular mass. It could be a TSH secreting tumor. TSH works by G proteins through GS and GQ. Intracytosolic nuclear receptors. What hormones work using that? Estrogen, progesterone, androgens, and glucocorticoids. You do a technetium-99 scan on the thyroid, you find a mass at the base of the tongue. That's not at the anterior of the tongue. What is this? Lingual thyroid. This is the most common location of ectopic thyroid. Keep in mind, it could be the only location of the thyroid, so if you remove it, it might leave the patient in a hypothyroid state. This patient tends to complain of dysphagia, difficulty swallowing, difficulty breathing, because when they have upper respiratory tract infection, you have the lymph aggregates within the thyroid that respond to that, and then they get enlarged, and then you're going to have the features of dysphagia, difficulty breathing, difficulty swallowing. What to give a pregnant woman with uncontrolled gestational diabetes that is not responding to diet and exercise change? Insulin. Remember, if they ask you, what does insulin work on? Tyrosine kinase receptors and downstream signaling. Inhibition of DPP4 are the gliptin. They work by prevention of breakdown of glucose-like peptide 1. Remember, glucose-like peptide 1 causes increased insulin release dependent on glucose, which is why giving a patient oral glucose is better than giving it IV, because this is what facilitates more insulin secretion and responding to that. So that's something to keep in mind. Blocking SGLT2 receptors, remember that works on the kidneys. We're going to prevent the absorption of glucose from the kidneys. So all that glucose is going to enter the urine, and then all that glucose is going to be used up by bacteria. So you're going to have urinary tract infection and candidiasis. Inhibition of alpha-glucosidase. So we can decrease glucose levels by simply preventing their absorption from the GI tract. So there's drugs called that prevent this brush border absorption, which work by inhibition of alpha-glucosidase, such as acarbose. If I'm not going to be absorbing that glucose in these large carbohydrates, what's going to happen is they're going to stay inside the intestine, and they're going to cause a hard time for the intestine. Basically, you're going to be bloated. You're going to have a lot of gas if you use acarbose. Vitamin D deficiency. So what does that look like if you're given labs? Vitamin D deficiency, you're going to have low calcitriol. If you're going to have low calcitriol, you're going to have low calcium. As a response of low calcium, you're going to have elevated PTH, which tries to work and increase that calcium again. And when the PTH increases, phosphate is going to decrease, because PTH, another way to remember, is a phosphate trashing hormone. So it's going to get rid of the phosphate into the urine. So vitamin D deficiency, it looks like low vitamin D, low calcium. In response to low calcium, you're going to have elevated PTH. In response to the elevated PTH, you're going to have low phosphate. The success of radioactive iodine depends on the transmembrane carrier called sodium iodide symporter, right? So I need that symporter to be working. I need it to be functional. So when I give the radioactive iodine, it gets absorbed into the thyroid gland, and then it can ablate it. So therefore, if I give something that prevents the function of this NIS, then that's going to affect the success of radioactive iodine therapy. So for example, that includes perchlorate, pertechnate, and potassium iodine. On the other hand, if, for example, you are exposed to high levels of radiation, if you take the potassium iodine, it's going to overwhelm the NIS. It's going to fill up the whole gland with this potassium iodine instead of the radioactive iodine. So it works both ways. Next, you get a patient with crampy abdominal pain, plus watery diarrhea, plus red face, plus heart murmur. Those are all buzzwords for carcinoid syndrome. So what's happening in carcinoid syndrome? You have a tumor that generally starts in the intestine or in the appendix. Once it metastasizes, it secretes serotonin. Once it metastasizes to the liver breaks down the serotonin, but it becomes overwhelmed. So then it enters the circulation, and then you're going to have all these symptoms. So on the level of the intestine, you're going to have watery diarrhea because of the serotonin. Then it goes to the lungs, where the lungs is the second place that can break down serotonin. And then you're going to have dyspnea and wheezes because of serotonin reacting there. And then when it overwhelms the lungs' capacity to break it down, it's going to pass, and before it does that, it's going to pass through the right side of the heart before it gets to the lung. The serotonin is going to damage the tricuspid valves, and it's going to cause pulmonary stenosis. And then it goes into the lungs, and it's going to cause features of dyspnea. And then once it overwhelms the lungs' capacity to break down the serotonin, then you're going to have features of flushing and skin redness, which is what you see in this case here. The other very high yield thing that you need to know is that when we are using up all of our precursors to make serotonin, you're going to be using a whole lot of tryptophan, and then that tryptophan is going to cause a niacin deficiency. So you're also going to have features of pellagra. So this can be a huge studying serotonin carcinoid syndrome is going to cover a whole lot of information for you, because you have features of endocrine questions here, cardiac questions here, as well as biochemistry questions here. So you're going to use up all of that tryptophan, and you're going to have niacin deficiency. So you're going to have pellagra, and the features of pellagra, remember, are the 3Ds: dermatitis, dementia, and diarrhea. Avipoma is due to increased gastric pH. It's going to cause increased gastric pH. It's going to be more basic. And WDHA syndrome, we said that's watery diarrhea, hypokalemia, and achlorhydria. T-cell lymphoma increases the risk of, is seen in celiac disease. A patient who is tired plus fatigued and has weight loss, you do a metyrapone tyrosine test. This will block 11-beta hydroxylase. So the normal response when you give this drug would be to increase ACTH. A 6-month baby is weaned from mashed potatoes to fruits. Now the patient presents with jaundice and hypoglycemia and enlarged liver and elevated liver enzymes. So what happened here? You have a baby, you stopped giving them milk, you started to introduce fruit into their diet, and now they're responding very poorly. This is a case of hereditary fructose intolerance. This is a deficiency of aldolase B, and this is autosomal recessive. You must avoid fructose all of your life for this. It breaks down fructose. Remember, you have fructose being converted to fructose 1-phosphate by fructokinase. This is benign. So this is a benign condition, and generally you find it in adults. And incidentally, when you're checking their urine, you find a 3+ reducing sugar. So that's what you find with benign fructosuria. There is no treatment for that, and it's benign. It's not going to cause any issues. The only other question you would have with that clinical vignette is what is the other enzyme that's going to be elevated in that case, which is going to be hexokinase. So hexokinase is going to increase because you have no fructokinase, and then when you convert the fructose to fructose 1-phosphate, you want to convert that into glyceraldehyde and dihydroxyacetone phosphate, and you need aldolase B for that, so that doesn't happen. So what ends up happening is phosphate is stuck in the fructose 1-phosphate, similar to how galactosemia works. So the phosphate is used up, so the high energy places in the body are not able to use that phosphate, so the liver becomes enlarged. You're going to have jaundice, elevated liver enzymes. The symptoms manifest at the time of weaning. The treatment is lifelong fructose and sucrose-free diet. Like we said, on the other hand, fructokinase deficiency is called essential fructosuria. It's an incidental finding in urine, and it is benign. A woman with a lump in her thyroid. You do a biopsy and you find cuboidal cells. You do surgery and it reveals histopathology of invasion of capsule and blood vessels. Those are buzzwords for follicular carcinoma. Pathophysiology involves PAX-A and PPAR gamma gene rearrangement. Remember, follicular is early invasion of capsule and blood vessels. It is the second most common type of thyroid carcinoma. If you get asked mutation of red proto-oncogene that is associated with medullary thyroid carcinoma, look for calcitonin producing C cells that stain with Congo red. And remember, association with Men syndromes. P53 mutation is going to be anaplastic thyroid carcinoma, very rare, very aggressive, very old. So you want an elderly person. This has a very, very poor prognosis. BRAF gene mutation, that's papillary thyroid carcinoma. Look for Samoma bodies and orphan Annie eyes. TSH receptor mutation is seen in toxic adenoma or multinodular goiter. Don't forget, again, because this question was repeated a lot, carcinoid syndrome will increase serotonin. Once it metastasizes to the liver, the body cannot detox it as well. The levels rise. The only other place for it to be metabolized is going to be in the lung. You'll have symptoms of serotonin in the GIT causing diarrhea, in the lung causing wheezing, and the heart causing murmur of tricuspid regurg and pulmonary stenosis. In the systemic circulation, the serotonin is going to cause red flushed face. All the precursors are shunted going to make serotonin. You're going to deplete tryptophan, which is needed to make niacin. Niacin deficiency is called pellagra. You have the 3 Ds, which are dermatitis, diarrhea, and dementia. A woman who is trying to get pregnant, the level of what is the best indicator that she has ovulated? That is progesterone. So we're going to take a look here. If you look at the luteal phase over here and the secretory phase, you're going to find that progesterone has levels steadily rise after ovulation. So a sign that she's ovulated is progesterone. Okay, a patient with thyroid carcinoma, your biopsy reveals ret/PTC chromosomal arrangement. This is papillary thyroid carcinoma. Look for calcified, you're going to hear the buzzword calcified sphericals or Samoma bodies, and large cells with empty appearing nuclei. That's orphan Annie eyes. PTC is the most common type of thyroid carcinoma, occurs at 80%, and has early lymphatic invasion. What has early blood spread? Follicular. Hyperplastic epithelium with colloid scalloping. That is Graves' disease. Remember that in Graves, the 2 specific findings are Graves' ophthalmopathy and pretibial myxedema. These are specific to Graves. Cuboidal cells with colloid lakes. That is follicular carcinoma. Look for RAS mutation, PAX-A, PPAR gamma mutation. You must find vascular or capsule invasion for the diagnosis. Sheets of polygonal cells with amyloid. That is medullary carcinoma. Medullary carcinoma stains with Congo red, associated with Men1 syndromes. Often it is treated with prophylactic thyroidectomy in these men. Giant cells with atypical mitotic figures, remember, anaplastic, rare, aggressive, old, P53 inactivation. Osteoporosis occurs in menopausal women. You will find decreased what? Decreased osteoprotein, decreased secretion of urinary osteoclastin, and increased expression of rank ligand. Stimulation of the rank ligand is going to stimulate the osteoclasts, which increase bone resorption and lead to osteoporosis. Excretion of urinary cyclic AMP is associated with hyperparathyroidism. A patient with non-controlled diabetes on metformin, you prescribe for him a drug that has delayed onset of action. Remember, delayed means it's probably working on the transcription level. The buzzword for a drug that works on the level of transcription. So think of a PPAR gamma activators, which improve insulin sensitivity by upregulating adiponectin and GLUT4 transporters, receptors on the adipose and muscle tissue. What is the side effects I need to know for these drugs? Weight gain, fluid retention, and they exacerbate heart failure. So they are contraindicated in patients who have heart failure and osteoporosis. Empagliflozin, I'm not sure if I'm pronouncing this right, is a SGL2T inhibitor. Again, we said these stop absorption at the level of the kidney, so you'll have polyuria and glucosuria. They increase the risk of candidiasis and UTI. DPP4 inhibitors like sitagliptin, they increase the level of GLP-1. We said GLP-1 induces the glucose-dependent insulin increase. So then you're going to have side effects of, what are the side effects of DPP4? Upper respiratory tract infection and pancreatitis. A patient with SLE, lupus, undergoes surgery. So keep in mind, lupus, she was probably on corticosteroids. She undergoes surgery, and now she's presenting with hypotension, hypoglycemia, abdominal pain, vomiting. She's going into adrenal crisis. This is a case of adrenal insufficiency. You want to look for hyponatremia. Why do we need to keep this in mind? Cortisol, when she's taking this exogenously, its high levels inhibit ADH secretion. So in this case of hypocortisolism, ADH will now increase, and now you're going to have free water retention and dilutional hyponatremia in response. You have a patient that takes calcium supplements daily. She now complains of stomach pain, confusion, short QT interval. These are all features of hypercalcemia and metabolic acidosis. In a case such as this, in a patient who's taking calcium supplements, I want to keep in mind a condition called milk alkali syndrome. This is seen in patients who take calcium supplements or antacids that contain calcium. You will find what? Elevated levels of 24-25 dihydroxycholecalciferol. Let's understand what's going on here. Antacids include aluminum hydroxide, calcium carbonate, magnesium hydroxide. Milk alkali tends to occur with those who are taking calcium carbonate. What happens is the increased calcium will cause metastatic calcifications and renal failure. In the setting of very high calcium, right, 25-DHCC gets converted to an inactive form called 24-25-DHCC, along with decreased conversion to 1,2,5-DHCC, because I don't want the effects of vitamin D. I already have hypercalcemia. I need the effects of vitamin D to produce even more, so I'm kind of just turning it into an inactive form, which is the 24-25-dihydroxycholecalciferol. Patient complained of left-sided weakness and acute confusion. She dies, and autopsy reveals microaneurysms in the lenticulostriae arteries and bilateral hyperplasia of the zona glomerulosa. Remember, primary aldosteronism will cause hypertension, which is called Conn syndrome. Remember that aldosterone causes reabsorption of sodium at the expense of potassium excretion. So look for muscle weakness due to hypokalemia. All you need to know is when you're dealing with aldosterone is going to cause increase in sodium because I want to pull up water with it and increase my blood pressure, and then at the expense of getting rid of hydrogen and getting rid of potassium. So if you have a lot of aldosterone secretion, and such as in the case of Conn syndrome, one of the issues you have to be aware of is hypokalemia. That is the cause of the muscle weakness. A 12-year-old boy, you find a reducing, this is a 12-month-old boy, you find a reducing agent 3+ in the urine. If you give him fruit juice, this will increase the activity of which enzyme? So remember, if we said before, this is a case of essential fructosuria. You just found incidentally 3+ reducing agent in the urine. So what are you going to do? In this case, the fructose is not being able to be converted into fructose 1-phosphate because you don't have fructokinase. But there is another enzyme that can take this function, that is hexokinase. So hexokinase will become the main enzyme responsible for the metabolism of fructose. A patient after surgery has perioral numbness. Remember, we said perioral numbness is one of the earliest signs of hypocalcemia. Look for QT prolongation. Impotence with prolactinemia. What is that? Impotence with prolactinoma in women. Probably meant to say men, and that was written incorrectly, sorry about that. In adrenal insufficiency, all three hormones are lost. The decreased aldosterone will mean that the sodium and water are lost in urine, so the ECFS will, the extracellular fluid will be less concentrated, so osmolality is going to be decreased, and relative to this, the ICF will be more concentrated. So it's going to look like this if you ever get a graph like this that you have to select. This is the correct answer. Patient with weight loss, diabetes, hypothyroidism, hyperpigmentation of oral mucosa. So I'm seeing signs of low cortisol. In response, there's ACTH causing the hyperpigmentation due to increased MSH. The mother and sister have the same problems. There's a family history. It's likely there's autoimmune. And this is the case of autoimmune polyendocrine syndrome too. You want to look for multiple endocrine abnormalities. Look for antibodies against adrenal steroid enzymes such as 17-alpha hydroxylase. Other disorders that can occur are alopecia, vitiligo, myasthenia gravis, and rheumatoid arthritis. A patient who has diabetes plus hypothyroidism is likely Hashimoto's thyroiditis. You want to look for anti-TPO or antimicrosomal antibodies. Patients with diabetes plus Hashimoto will have elevated HLA-DR3 haplotype. HLA-B8 is Graves', Addison's, myasthenia gravis. Papillary carcinoma, you're going to find dystrophic calcifications. Those are called psammoma bodies and orphan Annie eyes. Biphasic spindle cells on biopsy, anaplastic carcinoma. TSH receptor antibodies, Graves' disease. If you give a patient a high dose of phosphate, what will it do? So just keep in mind with everything. Increased phosphate means I want to get rid of it, right? So I'm going to increase PTH, and when I increase PTH, I'm going to increase calcium, and that will also increase activation of vitamin D. The most common cause of congenital hypothyroidism is thyroid dysgenesis. What is Beckwith-Wiedemann syndrome? Beckwith-Wiedemann syndrome, I think everything is big in this child. Big tongue, big abdomen, big beta cells. So one of the things that can happen with Beckwith-Wiedemann is their beta cells are secreting lots of insulin, so they will present with hypoglycemia. Increased risk of Wilms tumor. It's a WT2 mutation on chromosome 11. PCOS is hyperinsulinemia plus increased LH. This will stimulate the theca cells to produce androgens, which is why these women have Hirschism and alopecia and acne, because of the androgens. These androgens are then converted to estrogen by aromatase and adipose tissue. Androgen from the ovary and the estrogen from the adipose will decrease FSH secretion. That's what causes amenorrhea. The endometrium will continue to proliferate in these women under the effect of estrogen, but bleeding needs to occur when the progesterone starts to increase. But what you can do is something called a progestin challenge test. So that's going to cause differentiation of the endometrium, and then when you stop the progestin, it's going to cause withdrawal bleeding. That's one way to diagnose PCOS. Patient with daytime sleepiness, hypertension, red face, impaired concentration. This looks like obstructive sleep apnea. The cause of her red face is she's not getting a lot of oxygen, she has hypoxia, she's going to have increased erythropoietin and polycythemia. Increased bradykinin can cause angioedema, and that can be caused when you give a patient an ACE inhibitor. Carcinoid heart. Remember, if we talked about carcinoid syndrome, what are the signs of the carcinoid heart? Pulmonary stenosis, tricuspid insufficiency, and right-sided heart failure. Multiple ulcers and the GIT, that is buzzword for gastronoma. You want a case of somebody who is resistant to treatment. They're trying everything and they keep having symptoms of ulcers, plus ulcers in weird places, like we said, jejunum and ileum, and large ulcers, more than 2 centimeters. What are you going to find? Increased gastrin, increased chromogranin A. You want to look for thick folds. You want to look for increased serum gastrin, more than 1,000 picograms per milliliter. Do a secretin stimulation test. What is that? Secretin normally will inhibit gastrin secretion because you have a tumor, it's not inhibited, it's going to still remain elevated. It's not suppressed. On imaging, you use an octreotide somatostatin scintigraphy if you're asked what type of imaging you would use. Purple, red colored urine. That could be due to acute intermittent porphyria. Proximal muscle wasting is seen in Cushing's. Successive thyroid radioactive ablation depends on the NIS symporter. MODY2 is maturity onset diabetes of the young. It's due to defective glucokinase gene. It's not treated with anything other than diet and exercise modifications only. MODY3 is mutation of hepatocyte nuclear factor 1. It is going to cause abnormal insulin secretion and decrease in threshold for the glucose excretion in urine. Bone age, if you get this word, bone age that is less than chronological age. This is a buzzword for constitutional growth delay. This is due to decreased pulsatile release of GnRH at night. This is the most common cause of delayed puberty. Remember, for puberty to be triggered, it needs to be pulsatile. We usually have it continuous before puberty, and then once puberty hits, then it starts to become pulsatile. Prolactin is produced by the acetophils of the anterior pituitary. It works by the JAK-STAT pathway via non-receptor mechanism. Other examples that follow the non-receptor JAK-STAT are EPO, TPO, and GCSF. Insulin works through the receptor tyrosine kinase pathway via autophosphorylation. There's going to be downstream signaling. You're going to have PKB pathway and MAP-ERK pathway. The MAP-ERK pathway is going to be growth stimulation and increased gene expression. The PKB one is more related to the the glucose-related effects, such as increased glucose absorption, increased GLUT4, increased glycogen synthesis, decreased lipolysis. Decreased corticotropin release hormone, CRH, occurs in iatrogenic intake, which will suppress the entire axis. We've said this before. When fasting, what's going to happen is you have hepatic glycogen stores are going to be depleted after 12 to 24 hours. Then gluconeogenesis is going to occur to maintain the blood glucose. What does that is the PepC-K enzyme of gluconeogenesis. A baby born with subclinical hypothyroidism. The reason he is asymptomatic is because, so he has hypothyroidism. Why is he asymptomatic initially? Is because there is transplacental transmission of thyroxine. The maternal T4 can cross the placenta, which can support the infant for 5 to 7 days before they start having any real symptoms. The base of the tongue is the most common location of ectopic thyroid tissue. Even though it can produce thyroid hormone, it is usually not enough, so these patients are hypothyroid. And if you remove it, it could be the only thyroid tissue that's functioning, and it would cause the patient to have hypothyroidism if you remove it. Graves' disease, antibodies against TSH receptor antibodies. Acanthosis Necrocans is hyperpigmentation of the axilla, the back and neck. It is a sign of insulin insensitivity. The pathology is due to increased levels of circulating fatty acids. The increased fatty acids, essentially what they do is that they kind of just cover up the receptors and make it so that you would need more insulin to absorb that glucose. That is basically the foundations of the insulin resistance that you see. HLA-DR4 is associated with type 1 diabetes. A patient with kidney stones, stomach pains, can't sleep, hypertension that is resistant to medication. These are buzzwords for hyperparathyroidism. Remember, stones, bones, groans, and psychiatric overtones. You need to memorize these clinical features because it's constellation of features. Kidney stone, stomach pain, can't sleep, hypertension, can't focus. All of these look for signs of elevated PTH, and elevated PTH is a known cause of secondary hypertension. You find a case of a patient who is who is resistant to some therapy. You want to consider hyperparathyroidism. Another common cause of resistant hypertension is renal fibromuscular dysplasia. You want to look for decreased renal blood flow. A male patient with nodule in thyroid and high calcitonin levels. You want to think of medullary carcinoma. High calcitonin, buzzword for medullary carcinoma, from the C cells, which are derived from the lateral analogen endoderm. I have no idea how to pronounce this, but this is just a buzzword that I have to remember. Medullary carcinoma, C cells are derived from the lateral endoderm. The patient taking the drug sertraline and has a history of stroke now has hyponatremia and elevated ADH. So stroke is a cause of it can cause elevated syndrome of inappropriate ADH secretion. ADH increases the expression of, we said, aquaporin 2 channels in the distal convoluted tubule and the collecting duct, and increases absorption of solute free water from the urine into the systemic concentration. And therefore it concentrates the urine. So if I'm pulling water out of the urine now becomes more concentrated and has more solutes in it, increasing the osmolality of the urine and dilutes the serum, causing hyponatremia. So I've taken in this water that's solute free into my serum, and now that's diluted, so the serum osmolality has decreased, the urine osmolality has increased. Patients will remain euvolemic hyponatremia, because the plasma expansion increases, and ANP and BNP are also secreted, and there is a decrease in aldosterone in response to this. Patients with hyperosmolar hyperglycemic state, remember we said HHS, they have more than 600, generally up to 800, 850. 600, 650 is more DKA. There is negative ketones, there's no ketones, as type 2 still has some little function, functioning insulin reserve. Unlike DKA, where the body is forced to make ketones. Bicarbonate levels in HHS will be normal because there is no acidosis, and I don't need to use bicarb to buffer anything. Pheochromocytoma plus hyperparathyroidism plus a family history of male thyroid cancer, look for Men syndrome, look for RET mutation. Congenital adrenal hyperplasia is going to cause hyperplasia of the adrenal cortex. There will be low levels of cortisol in all cases, leading to feedback elevated ACTH, which is going to cause increase of the other precursors, which are going to be MSH, for example, which causes the darkening of the skin and the bluish gums. Levothyroxine is the treatment of hypothyroidism. It increases T4, which is going to be converted peripherally into T3 and reverse T3. So to ask you what you want to look for that this patient is taking levothyroxine, R T3 is going to be your answer. Symptoms of hyperthyroidism on scan So you have a patient who has symptoms of hyperparathyroidism. On a scan, it shows multiple patches of uptake. So multiple patches, think multinodular goiter. Look for patches with enlarged follicular cells distended with colloid. Crowded follicular cells with scalloped colloid. Remember, scalloped colloid, buzzword for Graves' disease. On a scan, there is diffuse uptake, not local areas. Follicular destruction plus lymphocytic infiltrates plus germinal center formation, buzzword for Hashimoto's. Sheets of parafollicular cells with amyloid stroma, we said this before. Medullary thyroid cancer arises from the C cells. Calcitonin, Men1 Syndrome, those are all buzzwords. Cushing disease is associated with pathological fractures. There's osteoporosis due to increased rank L activation, so these go and activate osteoclasts, which increases bone absorption as well as inhibiting osteoblasts. So Cushing's disease, osteoporosis. Patient complains of groans, thrones, moans, psychiatric overtones. We said that is hyperparathyroidism. You want to look for hyperplasia of what type of cells? Chief cells of the parathyroid gland. Hyperplasia of Kolchitsky cells, if you get asked, that is in the lung, that is a sign of small cell lung cancer. Hyperplasia of parafollicular cells in the thyroid, that is medullary carcinoma. Parafollicular cells in the thyroid, medullary carcinoma. Chief cells in the parathyroid is hyperparathyroidism. Hyperplasia of chromaffin cells in the adrenals, pheochromocytoma. Pheochromocytoma is a catecholamine secreting tumor, so we're going to get increased norepinephrine and increased epinephrine. It arises from the chromaffin cells, which arise from the neural crest cells. 90% are in the adrenals, 10% are located externally. One of them could be something called the island of Zucker-Kendall. It could be located in the bifurcation of the aorta or near the bladder. 25% are from germline mutations associated with many types of mutations. Men2A, Men2B, neurofibromatosis type 1, von Hippel-Lindau. These are all conditions where you might find pheochromocytoma. You want to look for the word episodic hypertension that can be triggered by foods that are high in tyramine, drugs, paroxysmal throbbing headache, palpitation, pallor, abdominal pain. One of the key things you can do during clinical examination, if they tell you did a clinical exam and while they're palpating the abdomen, his blood pressure rises, that could be because you're directly causing compression and secreting some of the norepinephrine and epinephrine from the tumor. You're going to have weight loss, you're going to have possible EPO secretion, plus other features of Men syndromes and all the other features of the other associated conditions with it. So if you have Men syndrome, you want to look for additionally pituitary symptoms or parathyroid issues. Neurofibromatosis type 1, you want to look for café au lait, Lisch nodules. VHL, you want to look for the whole constellation of a variety of tumors like renal cell carcinoma, hemangioblastoma, etc. Beware, hypertensive crisis can be triggered by abdominal examination if someone has pheo. Best initial test is plasma metanephrine. The confirmatory test is 24-hour urine. Clonidine suppression test is another test that you can do. Genetic tests to look for all the mutations that could be involved. Immune histochemical staining will find chromogranin, synaptophysin, and NSE. For those of you who have studied surgery, you would know that if you have a case of pheochromocytoma and you fail to exclude thyroid medullary carcinoma, you can trigger this patient to have so you want to be very careful because when you're on the table, it depends on what patient presentation you get first, and if you fail to exclude one thing or the other, because you might have a thyroid condition, you also might have the pheochromocytoma. So there's two things. When you are dealing with pheochromocytoma in the OR, you want to block alpha first, and then you block beta, right? Because there's hypertensive crisis. Block alpha first, and then block beta. You don't want to start with blocking beta, because if you block beta first, you're going to leave the alpha completely unopposed. So block alpha using phenoxybenzamine. So phenoxybenzamine, easy to remember, phenoxybenzamine, pheochromocytoma. Block using that, and then do beta blockers first. Now the key weird thing that you might get asked, I don't know if it's step 1 or step 2, but I just remember this from studying surgery, which is what ends up happening is if you are dealing with a thyroid patient, right, you have to be aware of something called thyroid crisis, which can happen, thyroid toxic crisis, which can happen while the patient is on the table. At the same time, the minute you induce anesthesia, and if you didn't realize maybe this patient might also have pheochromocytoma with their thyroid condition, you might also induce hypertensive crisis. So those are two things you have to keep in mind. Next is a prolactinoma. The serum level tends to be more than 200. If it's less than 100, look for another cause of hyperprolactinemia, such as hypothyroidism. What is going on here? Hypothyroidism would mean that there is no thyroid hormone being secreted, so the TSH is going to be elevated, and TRH, and then those two have functions on the lactotropes, namely the TRH, and those are going to cause hyperprolactinemia. But if the prolactinemia is less than 200, like we said, then it's probably the secondary cause. Prolactinoma tends to have levels above 200. Patient with celiac disease now has symptoms of hypercalcemia. Well, these patients have malabsorption, right? They're not going to be absorbing vitamin D from their GIT. So that vitamin D, that vitamin D2 that you can get from foods is called ergocalciferol, vitamin D2. Autoimmune destruction of the parathyroid is one of the most common causes of primary hypoparathyroidism. Look for HLA-DQ2 and DQ8. PAX8 and PPAR gamma is follicular thyroid adenoma and cancer. Second most common type of cancer, known for early invasion of the capsular vasculature. You need to see that to make that diagnosis. RET mutation is medullary thyroid carcinoma from calcitonin producing C cells. Look for polygonal cells surrounded by amyloid, which stain with Congo red. P53 mutation, we said, anaplastic thyroid carcinoma. BRAF gene mutation is papillary thyroid carcinoma. TSH works by GS and GQ protein signaling. Parathyroid hormone induces its effects by interleukin-1 secretion to activate osteoclasts. Osteoclasts are going to cause the bone resorption, remember, by binding to the rank L ligand. Alkaline phosphatase is often elevated in states of high bone turnover. Expression of rank L will also be elevated and its receptor will be increased. In the case of untreated maternal Graves, what is going to happen? So she has antibodies that are activating her thyroid. So these antibodies are going to cross the placenta. These are TSH receptor antibodies causing neonatal Graves and thyrotoxicosis. The baby will have tachycardia, diaphoresis, failure to thrive, hyperphagia because his thyroid is going to be enlarged, so you're going to have compressive goiter and stridor, and then microcephaly and craniostenosis. Macrosomia and shoulder dystocia, that will be occurring with gestational diabetes. Remember, we said high blood sugar in the mother is going to go into the fetal circulation, and in response, you're going to have insulin. Insulin is a growth factor for the fetus. Everything is going to be bigger. Macrosomia, shoulder dystocia, etc. Umbilical hernia plus erosive scalp lesion. This is a buzzword for methimazole use, called aplasia cutis congenita. You might find other things like choanal atresia and abdominal wall defects. Patient with new onset hyperlipidemia. You give them a medication that reduces the VLDL and LDL through inhibition of dialkyl glycerol acetyltransferase 2. This is niacin. It causes pruritus. That is the side effect of niacin. Niacin inhibits lipolysis and fatty acid release by blocking hormone-sensitive lipase. Remember, a woman with gestational diabetes that is not controlled with lifestyle medications, the only drug you can give them is insulin. It works on tyrosine kinase receptors. All women with gestational diabetes must first attempt lifestyle and testing 4 times daily. Insulin will cause dephosphorylation of fructose 1,6-biphosphatase, which is the rate-limiting step of gluconeogenesis. Dephosphorylation will inactivate this enzyme and also decreases the activation of protein kinase A. Insulin induces increased cellular uptake of potassium from the extracellular fluid. This is very important. So essentially, insulin decreases potassium, which is something you have to keep in mind because hypokalemia is something you have to be aware of when treating a patient who has DKA, because DKA, the patient's total body potassium is already low. If I give them insulin to treat their DKA, I may be causing more severe hypokalemia. So one of the things you have to keep in mind when treating DKA is to monitor potassium, and if its levels are low enough, you might need to treat the potassium, the hypokalemia first before you give insulin. Insulin increases upregulation of GLUT4 on the adipocytes and skeletal muscle cells. Insulin also increases the formation of UDP glucose. A vegan who does not go out in the sun now has fractures. We said that is due to decreased synthesis of cholecalciferol, vitamin D3 from 7-dehydrocortisol, which is the step that is catalyzed by what type of ultraviolet rays? UVB. What is the co-secreted with ACTH and MSH and works on mu receptors, beta endorphins. These 3 are broken down from POMC. ACTH, MSH, and beta endorphins. A patient with hyperparathyroidism, you do a technetium-99 scan, and we find 2 spots of increased uptake down in the mediastinum. So what happened here? Well, the parathyroid, the inferior parathyroid glands, with the thymus gland, they have the same original embryological origin, which is from the 3rd brachial pouch. The inferior parathyroid might still be connected and descended along with the thymus into the mediastinum. On the other hand, the superior parathyroids originate from the 4th brachial pouch. A patient with recurrent abdominal pain, foul, greasy smelling stools, gallstones, diabetes. So there's a constellation of symptoms, right? Recurrent abdominal pain, foul, greasy smelling stools. Okay, I'm thinking lack of pancreatic enzymes. Gallstones, I'm saying lack of decreased cholecytokinin. And diabetes, decreased secretion of insulin from the beta cells. So that is likely somatostatin. This hormone is primary inhibitory effect. Glucose intolerance to diabetes, like we said, due to pancreatic cell secretion inhibition. Diarrhea and steatorrhea due to decreased pancreatic enzymes. Gallstones due to inhibition of cholecystokinin release, which will reduce gallbladder contractility, leading to bile stasis, causing kidney stones. Increased activity of serine kinases is the molecular mechanism of insulin resistance. So, kinases will inactivate insulin receptor substrates through phosphorylation. This blocks the downstream signaling of insulin receptors and impairs the insulin signal and prevents GLUT4 expression on the surface. So if they ask you what is the pathophysiology of insulin resistance, it's due to serine kinases. In renal thyroiditis, you want to look for chronic inflammation. So renal thyroiditis is that large, hard, very firm thyroid gland. You want to look for chronic inflammation, collagen deposition. That's what's making it hard. Is the collagen and decreased number of follicles. The fibrosis can extend beyond the thyroid capsule. So if you're reaching the nerves, you're going to have hoarseness and dysphagia. May cause retroperitoneal fibrosis. Look for decreased limb pulsation and back acne. And you want to keep in your differential carcinomas because it kind of looks like a carcinoma with its compressive symptoms. Spindle cells with areas of focal necrosis. Anaplastic thyroid carcinoma. Decreased T3 can be seen in Thyroid 6 syndrome and is associated with Anorexia Nervosa. Treatment is not recommended as you must treat the underlying cause. So generally speaking, if someone is very ill for whatever reason, one example could be Anorexia Nervosa. Their thyroid is going to be Thyroid 6 syndrome. There isn't going to be anything other than slight decrease in T3. So that's Thyroid 6 syndrome, and it will resolve once you treat the underlying issue. Decreased leptin is a common finding in obese individuals. What's going on here? Leptin is produced by the body's fat cells, and its concentration is directly related to the amount of body fat. So an obese person would have more body fat, more leptin. Fasting will reduce leptin production. Technetium-99 thyroid scan shows arrested endodermal migration at the pharyngeal floor. So what is that? That's likely ectopic thyroid or lingual thyroid. The most common location is within the back of the tongue. It can enlarge, like we said, due to upper respiratory tract infection due to the thyroid lymphoid tissue, and then it will cause dysphagia and dyspnea. Persistent epithelial tract between the foramen and cecum at the back of the tongue to the thyroid isthmus describes thyroglossal duct. Failure of obliteration of the second brachial cleft is the cause of the brachial cleft cyst. Look for a neck mass that is located laterally and inferior to the pharynx. A 22-year-old patient comes to you for a checkup. All you find is the presence of a 3+ reducing sugar in his urine. So remember, he's 22 years old, and only now that you're finding out that he has a reducing sugar, this is essential fructosuria. There's nothing that you need to do about it. This is essential fructosuria, a benign disorder of fructose metabolism due to deficiency of fructokinase. In this case, hexokinase will increase inactivity and shunt the excess fructose back into the glycolytic pathway. Eliminate fructose. If you get asked in which case would you eliminate fructose and sucrose from the diet, totally that would be hereditary fructose intolerance. You're going to have definitely a patient who's much younger, who's being weaned, and you introduce fruit to their diet, then they have all of these symptoms of severe hypoglycemia, jaundice, hepatomegaly, failure to thrive. Theca interna cells in PCOS cause increased secretion of LH over so what's happening is there's increased secretion of luteinizing hormone, which overstimulates the theca cells, which will start to produce androgens and result in hirsutism. These are the endogenic features, the alopecia, the acne, the hyperinsulinism leading to insulin resistance. PTHRP is secreted by tumors. Remember that it's PTH-related peptide. It can be secreted by tumors causing hypercalcemia. Remember, one such example could be lymphoma, small cell lung cancer, etc. DKA causes decreased total body potassium. Always check potassium level before administration of insulin, which can further replete the potassium. Serum glucose more than 800, that is HHS, that is seen in type 2 diabetes. While DKA rarely exceeds 600, there is no ketogenesis in HHS due to some insulin function and no acidosis. 15-year-old patient did not start her period. She has no pubic hair. Her chromosomes is XY. Ultrasound shows streak ovaries, small uterus, fallopian tubes, elevated FSH and LH, but no estradiol. This is the case of phenotypic female, but genotypic male. She has the XY chromosome. This is gonadal dysgenesis or Sawyer syndrome, due to the defect in expression of testes determining factor on SRY gene. This defect in testicle differentiating factor, testes differentiating factor, prevents the differentiation of the gonads into the testes at the 8th week of embryogenesis. Insulin secretion is inhibited by alpha-2 receptor agonism and stimulated by beta-2 receptors. 6 months after pregnancy, patient has hypothyroidism. This is postpartum hypothyroidism. What do you want to look for? Lymphocytic infiltrate and disrupted follicles. And that's it for this video. Okay, I was surprised. I thought it would take much longer to get through this, but that's it for the endocrine high yield points. As you can see, some of them are very repetitive. Like I said, you probably would have benefited more if you've at least read the chapter at least once. And this is all of the high yield points that I could find in a variety of Q banks that I've been using, as well as from my notes and from the first aid book. So hopefully you guys found this video to be very fast, concise, and helpful, and full of the buzzwords and the factoids that kind of just you need to keep in your head for a while you're studying. And let me know in the comments what section you would like me to go through next. I'm definitely going to be going through all of them eventually, and I hope you guys are finding this useful. Please share it with people who you think might benefit, and I will see you guys in the next video.